Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me section on any of the websites listed in the podcast. Today, I want to give a shout out to Ignacio Guerrero, award-winning pioneer in the development of and research on group EMDR therapy, for his suggestion to include mention of limitations for each of the studies I review. Going forward, limitations will consistently be part of each study reviewed. Thank you, Nacho. In this episode, we will be taking a deep dive into the topic of using EMDR therapy with individuals with acute suicidal ideation. In the inaugural episode of the podcast, there was a brief review of the recent clinical instruction article by Kerkhof, Jongh, and Oppenheim that appeared in June 2025, How to Apply Eye Movement Desensitization and Reprocessing Therapy in People with Suicidal Ideations. In today's episode, I will interview two of the authors of that paper, Ad Kerkhof and Ad Jongh. But first, we will have an in-depth review of the research papers that provide the background to this topic. To access any of the research papers mentioned in this podcast, you will find a complete reference list with links to each of these studies in the October 2025 blog on sonomapti.com. Just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the October 2025 listings. Okay, let's get started. To provide some contrast to the latest clinical guidelines, let's start by asking what has been the historical and standard approach to working with suicidal ideation in EMDR therapy. In all three editions of her textbook on EMDR therapy, starting in 1995, Francine Shapiro emphasized the importance of establishing a strong therapeutic alliance when working with survivors of trauma. She advised clinicians to make sure that patients are willing and able to be truthful about their responses to EMDR therapy. She wrote, "Clients are reported to be at greater risk for suicidal ideation and suicide attempts when they feel greatly disturbed but withhold this information from the clinician." In a 2009 clinical Q&A article published in the Journal of EMDR Practice and Research, John Spector and Sandra Kremer each commented on what were then considered standard criteria for assessing safety and readiness for offering EMDR therapy to patients with suicidal ideation, such as assuring the willingness of patients to follow a safety plan should suicidal ideations increase. Neither commented on whether EMDR therapy might have direct effects on reducing suicidal ideation. It was not until 10 years later that the first controlled study to examine the effects of EMDR therapy on suicidal ideation in patients with major depression was carried out in Iran and published in 2019 by Fariduni et al. This study explored the effects of EMDR therapy on the severity of suicidal thoughts in patients with major depressive disorder being treated in a psychiatric hospital. Patients in the EMDR group received 9 EMDR therapy sessions over 3 weeks. Patients in the control group received antidepressant medication and no psychotherapy during the 3 weeks of the experiment. Severity of suicidal thoughts were assessed at pretreatment and post-treatment with the Beck scale for suicidal ideation known as the BSSI. Patients in the EMDR therapy group reprocessed traumatic memories, images, and symbols related to their suicidal thoughts. 80% of the EMDR-treated patients reported a single traumatic experience. 60% of these were adult experiences, 25% had childhood and adult traumas, and 15% reported only childhood traumas. Results showed that mean BSSI scores for those in the EMDR group were reduced significantly at post-test. The average drop was 15 points on the BSSI test. Control group BSSI test scores fell slightly less than 2 points, but these changes were not statistically or clinically significant. There are several limitations in this preliminary study. The authors acknowledged that they used a non-random, convenient sampling technique and did not check to see if patients met criteria for PTSD in addition to major depressive disorder. They did not report on any measures of depression severity, only suicidal ideation. There also was no follow-up data to determine if the reported changes were stable over time. The study is important, however, in suggesting that at least in patients treated in a psychiatric hospital, it was possible to reduce suicidal ideation in just 3 weeks of EMDR therapy. In 2020, another study was completed in Iran by Jongh et al. That assessed treatment effects on suicidal ideation at a residential center for vulnerable and homeless women who were female victims of child abuse and who ranged in age from 18 to 30 years. 15 women were assigned to treatment with EMDR, and 15 were put on a waiting list for treatment. Potential participants were excluded if they used medication for a condition other than PTSD, had a comorbid disorder other than depression or anxiety, had neurological, cardiovascular, or eye issues, or if they had a higher score than 16 on the Brief Dissociative Experiences Scale. The women all completed pre-test and post-test assessments with the civilian Mississippi Scale for PTSD, the Child Abuse and Self-Report Scale, the Mind Wandering Questionnaire, and the Beck Scale for suicidal ideation. Post-test results showed EMDR had a significant effect on reducing PTSD symptoms, mind wandering, and suicidal ideation. The average drop in BSSI scores in the EMDR group was 5 points, with no decrease in the BSSI score in the waitlist group. Limitations in this study included that the sample size was quite small, there was no alternate treatment condition, there was no follow-up data to assess stability of treatment effects. Further, it must be noted that treatment was offered within a residential treatment center with 24-hour urgent care and crisis intervention available. The authors did not provide information on adverse effects or whether any of the study subjects in either group needed to make use of crisis services during the study period. Still, this study provides further support for the hypothesis that EMDR therapy can reduce suicidal ideation. Another mental hospital-based study was carried out in the UK and published in 2020 by Proudlock and Perlis. They used a non-randomized convenience sample with a pre-test and post-test design. Patients who had experienced at least one traumatic event and who presented with suicidal ideation were offered 2 to 3 90-minute EMDR therapy sessions per week until they reported 0 or near 0 levels of subjective disturbance on their selected experiences, or they stopped improving, or they declined to continue. Measures included the Hospital Anxiety and Depression Scale, the Impact of Event Scale Revised, the Mental Health Confidence Scale, and the Interpersonal Needs Questionnaire. The Perceived Burdensomeness and Thwarted Belonging subscales of the Interpersonal Needs Questionnaire were used to infer suicidal ideation and urges. Scores on these 2 subscales of the Mental Health Confidence Scale decreased significantly by about 50%. Limitations of this study included unspecified numbers of EMDR therapy sessions, the lack of a control condition, the lack of a specific measure for suicidality, and a lack of follow-up data. The study did show that EMDR therapy could be used for patients in an acute mental health crisis and suggested the use of EMDR therapy could lead to cost savings in acute mental health care. Before going on to review the latest literature on treating suicidal ideation with EMDR therapy, let's take a look at reports related to EMDR therapy and the risk of increased suicidal ideation or attempts. Van Vliet et al. Reported in 2021 on a randomized controlled study in 2 Dutch outpatient clinics exploring whether phase-based treatment using stabilization with the stair intervention first is more effective than an immediate trauma-focused approach in people with childhood trauma-related PTSD, a group that is known to be at risk for suicidal ideation and suicide attempts. They randomized 57 participants to 8 sessions of stair stabilization, followed by 16 sessions of EMDR therapy, and a second group of 64 participants were directly treated with 16 sessions of EMDR therapy. Their primary finding was to discover support for the use of EMDR therapy alone for the treatment of PTSD due to childhood abuse, as opposed to needing any preparatory intervention. Now, I mentioned the study here because of the author's comments on suicidality. One potential participant was excluded who showed an acute risk of suicidality, as measured by Item 9 of the Beck Depression Inventory, which asks directly about thoughts and intentions to make a suicide attempt. During the study, one participant out of 57 in the stair EMDR group was briefly hospitalized after a suicide attempt. In the EMDR group, one participant out of 64 experienced increased suicidal ideation during the follow-up period. These adverse experiences support the recognition that suicidal ideation and suicide attempts can take place in survivors of persistent childhood abuse, either during stabilization interventions or during or after standard EMDR memory reprocessing. This reinforces the cautions mentioned at the start of this podcast episode to assure a sufficiently strong therapeutic alliance and patients' capacity to self-monitor and to report honestly on any increased disturbances during treatment, as well as essential steps in a safety plan. Many studies have documented that individuals with PTSD are at significant risk of attempting suicide. See, for example, an article by Serene et al., 2007, listed in the references in the October blog posting. But at the same time, suicidal ideation turns out to be a risk factor for dropping out of treatment for PTSD. Bremerhove et al. In 2023 found that individuals with low education level, problems in emotion regulation, suicidal thoughts, and high levels of general psychopathology showed greater likelihood of dropout during treatment for PTSD. Despite these risk factors for dropout during treatment for PTSD, EMDR therapy may be less likely to produce symptom exacerbation than some have suggested. In 2024, Meher et al. Examined symptom exacerbation during trauma-focused EMDR treatment in patients with personality disorders. In reviewing the available data, they reported that their results, quote, support the notion that although individual exacerbations in psychological distress and suicidal thoughts are reported during EMDR treatment of individuals with personality disorders, they are less likely to occur in response to EMDR therapy than those receiving no therapy at all, end quote. So it probably is important to consider the risks of exacerbation in comparison to no treatment or with alternative treatments to EMDR therapy. Now let's return to our primary topic, directly addressing suicidal ideation with EMDR therapy. For clinicians concerned about delivering EMDR therapy in person to individuals with suicidal ideation, well, what about offering EMDR therapy to those with suicidal ideation remotely via telehealth? This was the research question in 2024 when Burbach et al. Published a report on a randomized controlled trial investigating remote therapist-delivered EMDR for adults with suicidal ideation. 20 outpatient adults received EMDR therapy, and 20 other adult outpatients received treatment as usual, which included primary and mental health services available within the Canadian public health system. Inclusion criteria were being 18 to 65 years of age, reporting suicidal ideation in the past week, having an established and ongoing relationship with another healthcare provider outside the study, having access to appropriate technology, and a private space for online therapy, and committing to twice-weekly EMDR therapy sessions for the study duration. Exclusion criteria were severe dissociative symptoms or a dissociative disorder determined either through a diagnostic assessment or a dissociative experiences scale 2 score above 34. Nearly all of the participants in both groups reported a history of one or more suicide attempts. EMDR therapy participants received 12 sessions of web-based EMDR therapy delivered twice weekly via secure Zoom video conferencing. They also had access to treatment as usual. The treating clinicians were psychiatrists and EMDR certified in EMDR therapy. EMDR participants received psychoeducation about EMDR, developed a safety plan with a therapist, and had up to 5 preparation exercises. Participants had individual case conceptualization and treatment plans, which included identifying treatment targets associated with suicidal ideation. Participants in the treatment as usual group received both primary mental health services available without charge within the Canadian public health system, excluding only ECT or a different trauma-focused treatment. Primary outcome measures were the Beck scale for suicidal ideation, the BSSI, and the 5-item self-rated version of the Columbia Suicide Severity Rating Scale. Secondary outcome measures included the Beck Depression Inventory 2, the PHQ-9 for depression, the GAD-7 for anxiety, the Impact of Event Scale Revised for trauma-related symptoms, the DES-2 for dissociation, the Difficulties in Emotional Regulation Scale, the DERS, for emotion regulation, and the Adverse Childhood Experiences Scale. Most of these scales were administered 3 times at pretreatment and again at 2 months and 4 months after baseline measures were completed. ACE scale was completed only at baseline. The DES-2 and the DERS were repeated only at the 4-month time point. 18 of the 20 participants in the EMDR group participated in all 12 web-delivered sessions. There were 2 dropouts. One participant with panic disorder could not tolerate feeling bodily sensations. One participant dropped out due to family issues. Those receiving EMDR therapy that focused on suicidal ideation-related targets reported ongoing improvement across multiple symptom categories. Symptoms in the treatment as usual group appeared to trend downwards from baseline to midpoint and then worsened from the midpoint to the final follow-up assessment. For those in the EMDR group, there were significant differences in BSSI and CSSRS scores across all 3 time points. BSSI scores decreased by about 4.5 points, from an average of 16.5 at pretreatment to an average of 12 at 4-month assessment. The treatment as usual group participants reported significant decreases in BSSI scores across at the 2-month and the 4-month follow-up. However, their self-reported Columbia Suicide Severity Rating Scale scores went down at the 2-month assessment and rebounded back up to their original baseline scores at the 4-month assessment. The EMDR group also reported a significant decrease in depression and anxiety symptoms over the same time frame, while those in the treatment as usual group did not have changes in depression or anxiety symptoms. This study had several strengths. First, the study population reflected real-world complex psychiatric patients. The study design required individualized treatment, similar to how EMDR treatment is delivered in other real-world clinical settings. There were a number of important limitations. The sample sizes were small. There was no real follow-up data because the 4-month final assessment was only slightly longer than treatment duration for some of the cases. The total duration of treatment may have been too brief related to the early and long-standing suicidal ideation and the severity of trauma burden for most participants. This study took place during the worst of the COVID-19 pandemic, which may have added confounding stressors. Finally, the study excluded those with severe dissociative symptoms or a DES-2 score greater than 34, which further limits its generalizability to actual clinical settings where severe dissociative symptoms are not uncommon among adults with early onset and chronic suicidal ideation. On a positive note, as the authors state, quote, "This study provides preliminary evidence supporting the safe and effective use of web-based clinician-delivered EMDR as a transdiagnostic treatment aimed at reducing suicidal ideation and symptoms of depression, anxiety, and post-traumatic stress. It is also the first study to investigate the effectiveness and safety of web-based EMDR therapy in a real-world, highly complex psychiatric population." A qualitative follow-up to a 2024 controlled Canadian telehealth study by Burbach et al. Appeared in 2025 by Yop et al. Qualitative research is relatively rare in treatment outcome studies and is challenging to conduct. In this 2025 qualitative follow-up study, only 14 of the 20 eligible participants were able to be interviewed. Not all of them had completed all 12 sessions of the planned web-based therapist-delivered EMDR treatment. There was a wide range of participant experiences. Some said that biweekly sessions led to emotional exhaustion, while others desired even more frequent EMDR therapy sessions. A few study participants experienced difficulties. For example, one reported that there were times after sessions where I ended up feeling worse. It wasn't every time, but I definitely felt it after at least a couple of sessions. Most of the study participants reported post-traumatic growth, including improvements in self-perception, interpersonal relationships, greater self-confidence, a more open attitude towards others, a greater appreciation for life, and enhanced emotional regulation following EMDR therapy. The authors commented that, given evidence of PTSD subtypes associated with specific trauma types, future research may explore if there are subtypes of suicidal ideation associated with specific experiences and circumstances, such as life threat, loss, abandonment, rejection, moral injury, and humiliation, and that these might create unique suicidal states. The idea of possibly unique suicidal states links back to the individualized EMDR treatment plans developed for the original 2024 study by Burbach et al. These two research papers were the first to capture the experiences of individuals with suicidal ideation undergoing remote, web-based EMDR therapy. Their objective and qualitative findings may help inform the future delivery of psychotherapeutic care for individuals experiencing suicidal ideation. In 2024, Van Bentum et al. In the Netherlands published an outpatient, multi-center, randomized controlled trial comparing a modified version of EMDR therapy to treatment as usual, with the goal of reducing intrusive suicidal mental images in patients with depressive symptoms. 45 patients were given a modified version of EMDR therapy they called a cognitive dual task add-on, plus treatment as usual, and 45 patients were given only treatment as usual. Van Bentum et al. Refer to these suicidal mental images not as suicidal ideation, but as suicidal intrusions due to their involuntary nature. This concept of involuntary suicidal intrusions is congruent with the concept of involuntary intrusive sensory re-experiencing of disturbing memories in post-traumatic stress disorder. Inclusion criteria were, first, suicidality in the past month based on a score of 1 or more on the Suicidal Ideation Attribute Scale, depressive symptoms in the past 2 weeks based on a score of 20 or more on the Beck Depression Inventory 2, and a yes answer to at least one of 2 questions: do suicidal intrusions hinder you in your daily life, and do you feel tormented by these suicidal intrusions? Exclusion criteria were being diagnosed with a psychotic disorder, or depression with psychotic features, or bipolar disorder, or lack of internet access to answer online questionnaires, or a high dropout risk, such as failing to appear during initial screenings, or multiple no-shows for screening assessments. The version of EMDR therapy described as the cognitive dual task add-on module differed from standard EMDR therapy due to the omission of phase 5, the installation of the positive cognition. This cognitive dual task add-on module consisted of a minimum of 2 and a maximum of 6 60-minute weekly sessions provided at the patient's customary mental health care center by an EMDR-trained therapist employed at the center. Therapists decided when to end treatment, typically based on the number of suicidal intrusions that needed to be treated. The authors commented at length on the role of intrusive suicidal mental imagery. Suicidal imagery often presents as vivid, uncontrollable, and compelling suicidal images, such as imagining oneself during or right after a completed suicide, such as imagining taking an overdose, or consequences such as seeing your own funeral. They point out that these images can be either or both emotionally distressing and simultaneously comforting. Any feelings of comfort associated with suicidal imagery can be a risk factor for acting on such imagery. The primary outcomes were the severity of suicidal intrusions as measured by the Suicidal Intrusions Attribute Scale, and the frequency of suicidal intrusions as measured with the clinical interview for suicidal intrusions at pre-treatment, at 1 week post-treatment, and at 3-month follow-up. Other measures included the Beck Depression Inventory 2, the Rheumatoid Response Scale, and the Beck Hopelessness Scale. Nearly 90% of participants experienced suicidal imagery. More than 80% reported suicidal intrusions. Bilateral eye movements were delivered with a light bar. Targets for the most distressing suicidal images. At the 1 week post-assessment, the estimated mean on the Suicidal Intrusions Attribute Scale was over 27 for the EMDR group and nearly 45 for the treatment as usual group. The mean difference between groups was more than 17. Results also showed an effect in favor of the EMDR intervention regarding frequency of suicide intrusion scores. Shortly after the EMDR intervention, nearly 50% of EMDR therapy participants have recovered from their distressing suicidal intrusions, while less than 20% in the control condition had recovered. At the 3-month follow-up, more than 50% of the individuals in the EMDR group no longer had any suicidal intrusions. The average number of sessions needed was 4. There were no significant differences between the two conditions on depressive symptoms, hopelessness, or rumination. Treatment evaluation scores showed that the EMDR-like intervention was viewed positively. Over 78% agreed with the statement, "I was satisfied with the intervention." 72% indicated, "I would recommend the treatment to others." 81% agreed, "I found the treatment useful." There are a number of limitations in this study. The interventions offered in treatment as usual were not clearly identified, and there was no active comparison intervention. There was a 50% dropout rate at the 3-month follow-up assessment, in part because some of these assessments took place during the initial phases of the COVID pandemic. The measurement of frequency of suicidal intrusions was not actively tracked daily and depended on participant memories. Despite these limitations, this outpatient study demonstrated significantly greater decreases in suicidal intrusions in the EMDR-like condition than in the treatment as usual group, and found that the EMDR-like treatment was positively rated by 70 to 80% of participants. And now that we have completed a review of the research on the treatment of suicidal ideation and suicidal intrusions, let's go on to an interview with 2 well-known Dutch clinicians and researchers, Kerkhof and Jongh, who, with their colleague Hans-Jaap Oppenheim, published the clinical instruction article on treating suicidal intrusions in June 2025 in the Journal of EMDR Practice and Research. First, some background on the 2 guests who will help us understand the issues related to their recent article about EMDR therapy with the flash-forward procedure for intrusive suicidal images. Kerkhof is Emeritus Professor in Clinical Psychology, Psychopathology, and Suicide Prevention at Vrije University, Amsterdam, the Netherlands. As a clinician, he has extensive experience in treating suicidal patients. He served as editor-in-chief of Crisis, the scientific journal of the International Association for Suicide Prevention. He was chair of the board of the Amsterdam Institute for Postgraduate Education in Clinical Psychology, Psychotherapy, and Healthcare Psychology. Kerkhof was the first clinician to apply EMDR to patients with suicidal intrusions. Jongh is a psychologist and emeritus professor of anxiety and behavioral disorders at the University of Amsterdam. He is a visiting professor at Northumbria University, honorary professor in psychology at the School of Health Sciences of Salford University in Manchester, at the Institute of Health and Society of the University of Worcester, and at the School of Psychology of Queen's University in Belfast. He is a founding member of the Psychotrauma Expertise Center known as PsyTrek, where he works in the research department. He is an expert in the treatment of anxiety disorders and is actively involved in research on the efficacy of evidence-based trauma-focused treatments for a wide variety of patient groups, including children and adolescents, people with intellectual disabilities, and other complex psychiatric conditions such as personality disorders and psychosis. He has published more than 500 scientific articles, book chapters, and books in the areas of his expertise. He is an approved trainer for the EMDR Europe Association and is a former board member of the Dutch EMDR Association and the EMDR Europe Association. Thank you both for appearing on EMDR, the Science Behind the Therapy. In the first part of this episode, I provided background issues on how suicidal ideation in EMDR therapy has historically been addressed, and I also reviewed a series of research studies on direct treatment of intrusive suicidal images. Would each of you give our listeners a brief background to what led to your interest and involvement in the topic of suicidal intrusions and this recently published paper?
Okay, Andrew, I've always been deeply interested in understanding why people take their own lives. And for a long time, I felt that neither I nor the field as a whole truly understood the mechanism of suicide. I conducted many studies using well-validated instruments, such as the Beck scale for suicide ideation or the Beck suicide intent scale, and other commonly used measures. These tools were often used to predict recurrence. I remained dissatisfied in using these skills because I felt they did not touch the core essence of suicidal ideation. I was equally dissatisfied with the prevailing theories of suicide. They never fully explained the motivations of my patients. Something important was missing. And over time, both as a clinician and as a teacher of suicide prevention, I realized what we had overlooked, the role of worrying. All my suicidal patients worried excessively about their problems, about their future, about their treatment, their desire to die, and even about how they might carry out suicide. This led me to focus my treatment on suicidal worrying itself. I came to believe that the process of worrying could be the main driver pushing patients towards suicide. Some of my patients worried for hours each day, sometimes literally around the clock, even in their dreams. I also noticed that worrying was almost always accompanied by vivid mental images, visualizations of their future problems or of their own suicide. Patients often worried about these images. How many felt ashamed to share these images with their clinicians, fearing they might burden their caregivers. Yet these images became more detailed, more inescapable, and more tormenting. Patients described feeling compelled to end their lives just to escape the mental chaos. In these cases, the goal of suicide was not death itself, but release from compulsive thoughts and images, from relentless self-torture. So I came to see the suicidal images as a kind of obsession, much like OCD. Just as an OCD patient compulsively washes their hands, suicidal patients compulsively image their own deaths, hundreds of times a day. And this matches what Aaron Ringel described in 1976 as obsessive fixation in suicidal fantasies. He observed patients who, before killing themselves, experienced repetitive, obsessive, and highly detailed suicidal preoccupations.
So your recent publication on suicidal intrusions is the outgrowth of many years of research trying to understand the driving forces behind suicide attempts at Jongh. How did you come to this paper?
Yes, in 2014 we started to use flash forwards. And there were some studies, laboratory studies in the Netherlands that showed, it was 2010, 2011, they published these studies, and they showed that a flash forward, so a mental representation about the future, a catastrophic fantasy about the future, is as, if you try EMDR to focus on that flash forward, is as effective as if you would use a memory. That opened a lot of possibilities for EMDR because in my previous life, I was a dentist, so I was very much interested in dental phobia. But other phobias too. If you, for instance, have a person that is afraid of dogs, there's always that idea that dogs can bite and that you're not safe. So their mental representations are about dogs that bite. And we found out that if you address these mental representations and focus on these catastrophic thoughts, and you reach SUT 0, then people are going to think it doesn't make sense that dogs bite. Maybe dogs are not so dangerous. That was quite an extraordinary discovery, and other studies followed. So there are 3 types of mental representations people have. One are memories. The second one is our fantasies about what could have happened in the past, and the other one is what might happen in the future. These mental representations are very much alike in terms of how they respond to EMDR.
Kerkhof comes to this paper together with you from the direction of mental obsessions in general and then suicidal intrusions in particular. And De Jongh, you come to the paper from the perspective of flash forwards and EMDR being applicable to preoccupations about future events. And this provides a natural synthesis that leads you to write a clinical application paper, since there's now some research to support the effectiveness of this strategy. Fascinating the way these paths converge together. Now, earlier you mentioned the work of Erwin Ringel on the pre-suicidal syndrome. Now, I know you think everybody knows about this, but I suspect that there are some clinicians listening to the podcast who may not be familiar with Ringel's contributions to
He's quite
pre-suicidal
well known
syndrome.
around the world because he invented the concept of tunnel vision. And the tunnel vision is a state of mental constriction marked by impaired flexibility. When facing a suicidal crisis, patients feel trapped, hopeless, and overwhelmed. They believe there's no way out, and this sense of mental entrapment may drive them to attempt suicide. In the EMDR terms, they overestimate the probability and severity of the threat, they underestimate their coping abilities, and the associate negative cognition is, I'm powerless. The second component Ringel described is inhibited aggression, where aggressive impulses are turned inward against the self, often due to a harsh superego. In EMDR terms, this manifests as self-deprecating beliefs such as I'm not good enough or I always be a burden. And the third component is envisioning suicidal fantasies, repetitive, obsessive and increasingly dominant mental images of suicide, often down to minute details, and Ringel viewed these fantasies as a transdiagnostic marker of suicide risk. And the first two components are widely integrated into clinical practice worldwide, but the third, the suicidal fantasies or imagery, has rarely been addressed directly as a treatment target.
Fascinating. So it's these three elements together that Ringel brings together in his theory of suicidal syndromes. Now, these suicidal images that you say have rarely been addressed, how common are intrusive suicidal images in the general outpatient clinical population?
The wish to escape intrusions is the key to understanding suicide. In a systematic review of 23 studies on suicidal imagery by Lawrence in 2023, 70% of people in clinical samples reported suicidal imagery. However, her study did not address the intrusiveness of these images. In our randomized clinical trial, at least 80% of our outpatients with depression had intrusive suicidal imagery. In my clinical work, nearly 100% of suicidal depressed patients reported such images. I observed the same in suicidal autistic patients with depression and in borderline patients with suicide risk, so I believe that nearly all suicidal ideation has imagery and intrusive characteristics.
These intrusive and compulsive images, how much do you think they contribute to the increased risk of suicide attempts? If there's a way to ameliorate them, how much would that reduce the risk of a suicide attempt?
I think it's the biggest increase in suicide risk is when you have these images. All clinicians know very well the concept of intrusive images, but they regard it as something which you cannot take as a target for treatment. They think that treating depression will automatically decrease the intrusiveness of images or stop the images. In research, but also in treatment, we just didn't want to target these images because they're much too difficult, much too dangerous, and we didn't know how to deal with them.
Yeah, maybe it has to do with the fact that there's a big fear of therapists doing something wrong. Like addressing these images, focus on these images might increase the risk of suicide. We had the same with our research on psychosis. In the past, people thought, no, don't touch these delusions, because if you would address them and focus on these, become worse. But it's not true. If you dare to do it, you find out that these delusions disappear, that they more or less, with the SUD decreases, the SUD goes down, then there are not so much delusions anymore.
This fear of doing something wrong has been a major barrier to clinicians exploring the whole existence of intrusive suicidal images. So can you offer any practical suggestions for clinicians for how they can approach discussing this topic with patients in ways that could be helpful then to move the treatment plan forward?
Well, I said to the clinicians, just ask in a business-like way, how many hours a day do you have images of suicide? How often do you image being found by a passerby or by a daughter? How much time do you pass every day in seeing yourself climbing into a tree and making a knot and hanging from a tree or hanging from a ceiling? Just as a casual, business-like question. And patients are very happy that you ask for it, because you may be the first one who ever asked him or her this question. And they are willing to talk about it, but they do not present these images themselves, because one of the most suicidal cognitions is that you should not be a burden to other people, and you should not be a burden to your therapist. And people think they are a burden to the therapist when they express their intimate feelings and thoughts about suicide.
If clinicians adopt a similar attitude that they might have towards a patient with obsessive compulsive disorder, how much time do you spend washing your hands? How much time do you spend rearranging things in the kitchen? If you adopt that same business-like approach of very straightforward questions,
because
you can uncover
you have to wash your hands 50 times a day, or if you have to think about suicide 50 times a day, that's the same kind of obsession and compulsion.
Yeah, but addressing it, talking about it, the person feels understood.
Yeah.
Huh? Okay. Yeah.
And I think that the point that you make about the negative cognition of I shouldn't be a burden shows the barrier that patients have, despite their suffering, to disclose this aspect of their difficulty. And it's up to the clinician then to open up the topic and be very forthright, and as you say, businesslike in asking these kinds of questions. Now, in the paper, you provide a copy of the Suicidal Intrusions Attribute Scale, the SINUS. Do you believe it's better to start with the paper and pencil assessment, or to start with a clinical interview?
It doesn't matter which order you take. You may feel that it's better to start with the questionnaire, or it may be better to start with a question. But helpful is to start with a remark that you say that many patients feel ashamed for their suicidal intrusions, and just ask, is this the same for you? Do you feel ashamed for disclosing these pictures? In that way, disclosing to the patient that you are open for this experience and that you're not afraid of having to deal with their rather awful images.
So this builds the therapeutic alliance if you show empathy and take away some of the shame that the patient feels for having these kinds of preoccupations, then they immediately feel understood. So I'm curious then, if we think more about the flash forward protocol for intrusive suicidal images, how does this fit into a traditional overall treatment plan for patients who have suicidality? And we typically look at assessing risk factors and intent, control, and developing a safety plan for all treatment plans.
This is not very new, but it's already existing in the usual diagnostic system. We call it the case interview. And part of the case interview is to inquire about suicidal intrusions. But normally this is done very, very, how you call it, equivocally, but you can do it much deeper than that. And my suggestion is to include in the case a special section for intrusive thinking. We call this an add-on treatment. It's a treatment which you add on an existing treatment. So you can add it on a safety planning program. You can do it add-on in an acute service, or you can do it in an add-on in a treatment right after a suicide attempt in hospital, or you can add it on to a cognitive treatment of cognitive behavior therapy. Because in all of these treatments, there's the goal of self-reflection. And in EMDR, the main thing that is the outcome of this treatment program is a better self-reflection. So it speeds up the process in the other therapies. It's just highly efficient.
It's a remarkable contribution, and I know from my own experience since the paper came out and looking at the literature, it's something that I've begun to include in my clinical practice. But one of the questions that comes up in consulting about these cases is that when you get started with the flash-forward protocol for intrusive suicidal images, how should EMDR clinicians decide on which target to select first? For example, if intrusive suicidal images started after a particularly traumatic or humiliating experience, should the clinician start with the past memory or with the most disturbing current intrusive?
I think it's better to start with the intrusive flash forward.
So first, the prevention of the suicide goes first, you say?
Yeah.
Yeah.
I've had many clients who have been treated also with EMDR for events or traumatic events or rape or whatever. And they also had flash forwards for suicide, because a lot of times flashbacks transform into flash forwards. For example, a patient remembering anxiously the rape of her father and is afraid that these anxious memories, these lively imaginary memories, are going to haunt her the rest of her life. Then it becomes a flash forward, because they fear that they will, in the future, repeat the memories of the past.
So then would it be fair in EMDR terms, Jongh, to think about this the way we think about the inverted protocol for patients who maybe aren't quite ready to go into the past, and so we start with current triggers or flash forwards? In this case, we want to reduce the risk of another suicide attempt, so we don't follow the traditional past, present, future protocol, but we start in the future, irregardless of the fact that these intrusive images may have begun after particular events in the past. They were the cause of them, but now for safety planning, we start with the flash forward instead.
Yeah, the most important things first.
So this is a change in perspective about treatment planning for many EMDR clinicians who are locked into, we have to start with the first memory. And this is a different strategy because it's focused on safety and creating safety by reducing the intrusive imagery.
So even if you have a flight phobia, then you start with the mental representations about the future. If that goes down to a certain zero, then people don't feel that so anxious anymore of flying. Next, you can say, are there any memories in the past that are needed to process too? But most of the time, people don't know exactly when these fears or phobias started. They read something on the internet, they heard some rumors from other people, or read something in a magazine about flying, but it never crashed before. So I would always say start with anticipatory anxiety, start with a flash forward. So it's not different in this way.
It is a difference from the way clinicians have been trained. Most clinicians have been trained to do past, present, future. And so it's important to emphasize that particularly when dealing with phobias and intrusive imagery about the future, we don't begin in the past, regardless of what may have precipitated these. We begin in the future. And then after the intrusions have been brought down to a zero, then we can deal with the past.
People have intrusive memories before they are being bitten by it. Then you could say, yes, of course, I'm start with the memory of being bitten by a dog. But if the patient has symptoms of the future that he is afraid, anticipatory anxiety, because he doesn't dare to leave his house because he thinks, then I will be attacked by a dog. The symptoms are not so much about past, but the symptoms are totally related to what's about the future. So start there.
Yes. Now, this idea of the most concerning symptom with depressed patients is the suicidal intrusions. And so that's where we begin the treatment plan. Now, another area where clinicians often struggle is with the selection of negative and positive cognition. Can you comment about how EMDR trained clinicians should select the negative cognition and the positive cognition? The article gives the example of a negative self-statement associated with some past experiences, I'm worthless, but then suggests that for the flash forward procedure, the negative cognition should be I am powerless or I can't handle it. Why is that? Why do we use the lack of control?
The central thing of the flash forward is that you are not able to get rid of it. So you're more or less powerless against the flash forward. So that's the negative cognition. So we use a standard negative cognition for the flash forwards. I'm powerless against the future image.
This grows out of the subjective experience of the helplessness over the intrusion that leads to the selection of the negative cognition. I'm not in control,
more or less
or
a
I'm helpless.
And that produces anxiety. And the anxiety about this powerlessness also puts people into this urge, this intrusion, of which they are afraid. And they are afraid to do something they don't want to do, but they are obsessed by their anxiety for the possible future and to lose control. And they are afraid of losing control. And what happens if you are afraid of losing control? Then you do exactly what you are afraid for.
Makes sense.
It makes sense to me, but then I've read the paper and I've looked at the literature and been thinking about this for a while now, but clinicians listening to this for the first time are going to find this is really eye-opening because it's moving them in a new direction. One thing I was really pleased to see in the clinical instruction article that you published in the Journal of EMDR Practice and Research is that you recommend following the standard EMDR procedures and you included the installation of the positive cognition in phase 5. And this contrasts to the Van Bentham et al. Article that omitted the installation phase. In your article, you suggested that Van Bentham et al. Results might have even been better if they had included the appropriate positive cognition, such as I can look at it. Can you comment any further on the benefits of including the positive cognition in phase 5 of the flash forward procedure for intrusive suicidal images?
In the Van Bentham study, it was omitted because it's the installation of a positive cognition is really the same as asking people to go back to the target. You can look at it. You are able to look at it. You can deal with it. We thought, okay, it makes the procedure a little bit shorter for research emphasis. It really isn't new because really in the procedure of going back to the target, you repeatedly said, come and look at it, go and look at it, which is the same as installing the PC. But now we are after this research, we think it's better to do it again and make it an official part of the procedure to install again the positive cognition. And why not? If you have time to do it, please do it.
Actually an omission there in the protocol. And now we say, hey, put it back.
Yeah.
Go to the standard protocol back.
I think it strengthens the sense of mastery that patients have over these formerly intrusive images, that if they come up, they say, I can look at it, instead of, oh no, I have to try to push it away. The more they're trying to avoid it, the more power they get to it. When they can look at it and go, I can face this now.
When you install the statement, that it feels true. Huh? It's believable. Yeah.
It feels true. I'm wondering, some patients report having positive feelings, such as comfort, associated with their intrusive suicidal images, or sometimes they have a mixture of positive and disturbing feelings. Are there any special considerations in working with these patients?
It is quite simple that these positive feelings about intrusions are the inverse of the negative feelings. So it's a relief from pain, or it's a relief from anxiety.
It's like coping.
It's a way of coping with anxiety, but it really is another way of telling yourself, I am scared. I'm scared now, And I hope that when I commit suicide, I will have rest. I can sleep finally. Also, this is another way of telling yourself that you are scared and that you now don't know how to sleep with this intrusiveness.
One of the thoughts that I have, if this makes sense to you, is that many clinicians think that EMDR can only reduce the level of emotionality for negative emotions, but there are dysfunctional positive emotions also, and this feeling of comfort associated with the suicidal images is actually a dysfunctional positive emotion. It's covering over that fear that you talked about. And so targeting that comfort actually will also go down.
Has been shown in laboratory studies that there's no difference so much between negative and a positive arousal connected to the target image. It decreases. So also positive arousal decreases when you process the memory.
Yeah, it's the two sides of the same coin.
So clinicians should not be afraid of targeting an intrusive suicidal image associated with a feeling of comfort. It will also become disempowered.
Yes.
It'll become weaker and the SUD will go to zero. How about in situations where doing the flash forward procedure on intrusive suicidal images and the SUD does not initially drop to zero? Are there any specific EMDR interventions that you can encourage clinicians?
If the SUD doesn't decrease within half an hour, something goes wrong. That means the mental representation in general is not in the working memory, or the patient has such a large capacity of their working memory that you need to add more working memory taxation. So I work in a clinic with PTSD patients, and we see 150 of PTSD patients per month. Many of them, let's say 10, 20%, they have a large working memory. So the SUD doesn't go down if you don't tax it more. Faster eye movements that are closer, additional tasks like tapping and eye movements, spelling tasks we use a lot. So sometimes the SUD doesn't go down because you're not taxing the working memory enough. The other thing that you see is they don't place it in the working memory. So that's a way of looking at it. We call it EMDR 2.0. It's another way of looking at it. But in our situation, it doesn't happen so often if you use more working memory.
So the first and the most important point you're making is when the SUD is not going down to zero, increase the taxation of working memory by speeding up the eye movements, making them narrower, adding a second form of bilateral stimulation, or add another task in parallel with the bilateral eye movements to challenge the working memory system. And the second idea is that some patients are actually avoiding the material.
Yeah.
They say they're thinking about it, but they're not actually bringing it up into memory. So in these cases, we remind them of their own verbal descriptors. We read them back to them from our notes about what's the most disturbing part. Now, some patients obviously have more than one intrusive suicidal image. How many different flash forward sessions might an EMDR-trained clinician need to offer to achieve a good therapeutic benefit with, say, a typically severely depressed patient?
In the research of Van Bentham, we needed only 4 sessions to decrease the most important suicidal image. But there may be more images, and then you can treat them one after the other. And you could also ask the patient how many intrusions they have. Mostly there will be 1 or 2.
Yeah, 1 or 2.
1 or 2 will do. When you treat one suicidal intrusion, the other one is also treated as well. And then they cannot make the intrusions anymore. So it's quite efficient.
So just to recap, after these intrusive suicidal images have been successfully treated down to a SUD of 0, then the EMDR treatment plan goes on and deals with, for example, past experiences that trigger depressive episodes. This is just the beginning phase of a comprehensive treatment plan. What other research projects are you involved with, especially related to the subject of intrusive suicidal images that our listeners can look forward to in the future?
There will be some replications of the study in Canada and in Denmark. And we have some studies now going on for young people with suicidal intrusions and for people with depression and autism. So there will be some more research going on, and especially I think that many clinicians will adopt this technique, as they already have done so after this publication. But I myself, I'm retired, so I will not be involved anymore in ongoing research, but I will be in touch with the researchers and promoting them and helping them to do a good job.
Maybe it's interesting to know that you are providing trainings for clinicians in the mental health care institutions in the Netherlands.
Yeah.
That's a one-day training, isn't it? That are already been trained in EMDR.
Yeah, it's a one-day training. But many EMDR therapists do it without the additional training. They just practice their normal flash-forward protocol to the suicidal intrusion. So it's quite easy for experienced EMDR therapists to do. So
do you recommend the article, and do you think that's enough for for someone who's already trained in EMDR?
Who's already trained with flash-forwards can do easily without any training to the EMDR protocol for suicidal intrusions without any problem. Even more, I met quite a few EMDR therapists who didn't know about research, who spontaneously already did this for their suicidal patients. So it's quite understandable.
The only thing is that you have to courage.
You have to have courage.
Thank you both for bringing forward the clinical direction article that you put in the Journal of EMDR Practice and Research, and thank you for your generosity today in sharing your insights about how EMDR-trained clinicians can help individuals overcome their suicidal intrusions with the flash-forward procedure. In the first section of this podcast, I reviewed findings on the use of EMDR therapy for individuals with suicidal intrusions. The early studies focused on using standard EMDR therapy for treating disturbing life events associated with suicidal intrusions. These studies showed some reductions in suicidal intrusions. However, the 2024 Van Bentum et al. Study was the first to shift from standard EMDR reprocessing of disturbing life events to studying the use of the flash-forward technique directly on suicidal intrusions. The 2024 Van Bentum study found significant and stable improvements for the vast majority of participants with no adverse effects related to the treatment intervention. EMDR-trained clinicians interested in helping patients resolve suicidal intrusions with the flash-forward technique will find most of the guidance they need in the June 2025 clinical instruction article by Hans-Jaap Oppenheim, Ad Kerkhof, and Ad Jongh. The article provides readers with the Suicidal Intrusions Attribute Scale, the SINUS, and includes a detailed description of how to use the flash-forward technique to treat suicidal intrusions. As Ad Kerkhof emphasizes in the interview, suicidal intrusions are the primary risk factor in suicide attempts. He recommends that clinicians reduce the shame felt by patients with suicidal intrusions by taking a matter-of-fact approach to helping patients describe their intrusions and monitor their progress using the SINUS scale. As Ad Kerkhof and Ad Jongh comment at the end of the interview, EMDR-trained clinicians simply need the courage to discuss this essential issue with their patients and the readiness to use the flash-forward technique to reduce their suffering and the risk of future suicide attempts. That's it for today's episode of EMDR, the Science Behind the Therapy, from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. To explore the research mentioned in today's podcast, check the episode notes for links and references. All the articles covered in this third episode of the podcast can be found at sonomapti.com/blog in the October 2025 listings. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on EMDR training programs, visit sonomapti.com, and for free articles, visit the resources section on andrewleeds.net. Thanks again for listening. We'll see you next time.